It's a pleasure again to be back here. So I'm going to talk about neuropsychiatric manifestations in the APS, and I apologize if for some of part of this topic, perhaps there is a little bit of overlap. So we have a broad range of manifestations in these patients in terms of neuropsychiatric features. They can go from focal symptoms to more global dysfunction. And it was indeed from the early days of the description of the syndrome by Dr. Grant Hughes and his team at the Hammersmith Hospital at that time in London in the early 80s. And from the beginning, it was highlighted how this patient could present with cerebral ischemia, but not only, also with other type of neurological disease. And in particular, myelitis was described from the early days. And you see in these busy slides a list of various manifestations. And the first you see in the top part of the slides, they are basically clearly thrombotic in type. And this is some MRI of a patient who had a concomitant SLE apart from antiphospholipid syndrome. And you can see in this MRI scans that there is quite a lot of in terms of ischemic changes, and also cortical atrophy. So it is well established, the association between antiphospholipid antibodies and cerebral ischemia. And indeed, TIA and stroke are the most common arterial events in antiphospholipid syndrome. They can be thrombotic or cardioembolic. Antiphospholipid antibodies are strongly associated with stroke in young patients, with the estimated percentage of 20% of stroke under the age of 50 related with the antiphospholipid antibodies. And the study by the NEUROPSYCHIATRIC Project group led by Riccardo Cervera described a prevalence of stroke in APS patients of almost 20% and TIA just above 11%. And the Italian project on stroke in young adults looked at more than 1,800 patients who had ischemic stroke at a young age, less than 45, and they established a 10-year risk of recurrence that was 3 times higher in APL-positive patients. And a study systematic review by Savino Shasha and the APS Action Group estimated frequency of antiphospholipid antibodies in young adults with the cerebral events basically was 70% for stroke and almost 12% for TIA, with a 5-fold higher risk for patients who have future events. So the message is quite clear and simple. You have a young patient with a stroke, especially in the absence of underlying conventional cardiovascular risk factors, well, think APS. These other manifestations that you can see here, highlighted in blue, they are not so clearly thrombotic in origin, or at least not always you can find evidence of underlying thrombosis. And there are various. They include seizures or headache, migraines in type sometimes, chorea, movement disorders, multiple sclerosis like features clinically or radiologically, myelitis, idiopathic intracranial hypertension, transient global amnesia, and cognitive dysfunction and dementia. So one of the problems when we talk about this kind of manifestations that we would call non-thrombotic, well, we face various issues, and one of them is that there is a concomitance of SLE and antiphospholipid syndrome in many patients, and so it could be difficult to establish exactly with a clear-cut differential and what is due to one condition and the other. Many manifestations that we have seen earlier in that slides are also strongly associated with SLE. Could be difficult to differentiate between inflammatory and thrombotic mechanism. So the pathogenesis is poorly understood, and certainly the role of antiphospholipid antibodies in these cases. We can talk about microvascular thrombosis, and this can be a mechanism in some cases, but other times you cannot really explain all these manifestations by microvascular thrombosis per se. And you would have other type of immune-mediated mechanism that can play an important role here. In particular, immune-mediated neuronal damage. These antibodies can bind to neuronal cells, glial cells, myelin, can activate the endothelium, can activate the complement. And you have various evidence from numerous animal models. And also today, our colleague, Dr. Fugedo, presented an elegant study, an animal model, proving also that definitely there is something in terms of neurotoxicity happening in the brain in relation with the antiphospholipid antibodies. So we are quite fortunate in our institution to have a very close collaboration with other colleagues from other disciplines. And in particular, we have established a clinic with a neurologist, a combined clinic, and we see the patients together. And we have a good support from other specialists, including psychiatrists. And we see together some of these complicated patients. And I'm not going to talk much about that, but I would like probably to talk about one case at least. So it's not about seizures. Seizures is another extra slide, and I eliminated this case because otherwise it was taking too long. Seizures, as Dr. Appenzeller explained earlier, strongly associated with antiphospholipid antibodies, and there is a clear evidence of that. Reported in up to 10% of patients with antiphospholipid syndrome. They, of course, can be related with underlying ischemic lesions, but not always you can prove that, and there is an independent association also with antiphospholipid antibodies in the absence of stroke. Risk factors include smoking, livedo reticularis, and valvular heart disease. Headaches are common. They can vary from classic migraine to other kind of headaches, even chronic daily incapacitating headache. Graham Hughes' observation long ago, he was very keen on trying to identify patients that would benefit from a particular approach in terms of management of their headache. He noted that patients receiving anticoagulant treatment because they had thrombotic events, in some cases would report a dramatic improvement of their headache. Patient who had a daily chronic headache all of a sudden was clear of their headache. And so this observation led our group many years ago to run a study that we designed between us in the lupus clinic at that time, and was a double-blind crossover randomized trial comparing molecular weight heparin versus placebo in the treatment of chronic headache in APL-positive patients. We were pretty sure to find a dramatic difference there, but the outcome was that there was no significant difference between the patient receiving low molecular weight heparin and placebo, and in terms of severity and duration of the headache. So we were a bit disappointed. Last year, there was this retrospective study published about 75 patients in the Lupus Journal. And there was a description of a clinical improvement with aspirin, clopidogrel, and anticoagulation, mostly apixaban, in this group of patients, 47%, 83%, 94% respectively, with a major clinical response that was defined by 50 to 100% improvement in terms of frequency of headache and severity of headache in 21% patients who had aspirin, 67% of patients who had clopidogrel, and 85% of patients who received anticoagulation. So perhaps there is something there, but it would need to be proven by a proper design study. And just to make things more complicated, and not probably so easy talking about anticoagulation or other type of approach, but this is just a clinical case, someone who saw in clinic and proved challenging. This gentleman, quite young man, had a severe headache, and initially 1, then 2 episodes a week for about 1 year, and they were quite debilitating. The frequency became more severe, more frequent, and the episode very severe, 3 to 4 episodes a week, lasting for 4 to 5 hours. He was unable to function. He had no visual changes or aura, and no previous medical history of note. He was initially seen by a neurologist, and he was found to have on MRI a diffuse dural thickening. There was no evidence of cerebral venous thrombosis. He had a proper angiogram done, venograms, and lumbar puncture showed a normal CSF. He had a weak positivity for antinuclear antibodies, but the rest of the relevant SLE serology was negative, ANCA negative, inflammatory markers normal. And they tested a bit of an enlarged panel of antibodies, including antiphospholipid antibodies. Not entirely clear why, because there was no proven thrombosis here, but they found he had strongly positivity for cardiolipin and beta-2 GP1 antibodies. That was even confirmed with a positive lupus anticoagulant as well. So the diagnosis was of pachymeningitis based on this finding, especially on the MRI. And the patient had extensive investigation because the first thing we would think of is that he had a TB or sarcoidosis or GPA. Also, we thought about CNS vasculitis, and we were talking about trying to get a brain biopsy as well. The neurologist wanted to start some sort of treatment first. He had such a striking positivity for the antiphospholipid antibodies that empirically it was attempted to give him anti-aggregant treatment, which didn't work, then warfarin with INR range 2 to 3 with no change, increased to 3 to 4, no change, then became quite erratic and went too high, no improvement anyway, so stopped anticoagulant treatment. The neurologist was keen to treat with steroids at this stage and used a quite high dose of steroids, at least for us in rheumatology we'll use a little bit less. It was 1 gram per day for 5 consecutive days, and the patient became completely asymptomatic. He was also on aspirin, of course. Then he was given oral pred, 50 milligrams a day, no headaches, reduced gradually. When he was on 25, he was still fine, totally asymptomatic. When he went down to 15 milligrams a day, he started having some headache back, but not too bad. Then steroid-sparing agent with azathioprine was added, and the steroids in the end were stopped, and the patient continued doing well. He had occasionally very mild headache that was basically not relevant to him, and he was very happy with this progress. He remained on azathioprine only and aspirin. So we didn't know exactly what to make of all this, but there was this interesting case report from Japan describing a similar case, a novel type, according to these authors, of hypertrophic pachymeningitis associated with antiphospholipid antibodies in a patient who had already a history of antiphospholipid syndrome. In their case also, there was no improvement with anticoagulation. The improvement clinically was related with the use of anti-inflammatory treatment with steroids. They obtained a brain biopsy and they found that there was dural matter fibrous thickening, thrombosis of dural microvessels, and quite a lot of inflammatory component with a T-cell infiltration. So it's something that brings probably to attention that in terms of headache, things sometimes are not so simple in terms of using anticoagulant treatment, yes or no, and perhaps there is something more there that we still do not entirely understand. Chorea is strongly associated with antiphospholipid antibodies. It's a rare condition, but has been well described in a larger cohort. Up to 3% of patients with SLE and antiphospholipid syndrome. It can be bilateral, almost in half of the cases, but only in 1/3 of the cases you would be able to identify underlying ischemic changes, and one would suspect that perhaps there is some sort of a neuromediated toxicity there with antiphospholipid antibodies possibly doing something like binding in basal ganglia. And as Dr. Appelleser explained earlier, multiple sclerosis-like disease, well, clinical and radiologically, at least at first sight, some imaging can be difficult to differentiate and be able to tell for sure this is MS, demyelinating disease, inflammatory disease, or APS. But with a more in-depth assessment of patients, I think that in most of the cases it's absolutely possible to make sure whether or not the patient has MS. Myelitis is also strongly associated with these antibodies, and from the early days, I think there was a description of myelitis, as we said earlier, in the presence of antiphospholipid antibodies. What happens here is not entirely clear. It's basically the same, because not always you can prove an underlying ischemic process in patients who had or have myelitis, and an inflammatory component can play an important role. And as I said earlier, we think that perhaps antibody-mediated damage is also part of the picture. These patients usually are treated with immunosuppressant treatment, but if they have positive antiphospholipid antibodies, there is a case to consider anticoagulation in the beginning. You want to get rid of the symptoms and the process of the disease to try to avoid a permanent damage in this patient. So probably you use everything you got and quite quickly as well. And our group reported an association between antiphospholipid antibodies and transverse myelitis in patients with SLE and also with patients with lupus-like features that later on developed definite lupus. However, we need also to take in consideration that over the past few years, in particular, there are various cases of neuromyelitis optica or neuromyelitis optica spectrum disorders that were initially diagnosed with antiphospholipid syndrome, that actually they had a neuromyelitis optica spectrum disorder. And we need to be cautious as well in these cases. I mean, a patient with an MOSD, you need to look for aquaporin 4 antibodies that are found in more than 75% of patients. They are very specific. If they are negative in half of them, you would find the MOG antibodies. These patients, 25% of them will have a coexisting autoimmunity. This could be SLE, could be Sjogren's, could be another autoimmune disorder, could be even autoimmune thyroid disease. But it's well known that they have concomitant autoimmunity. And to have someone with lupus and neuromyelitis optica, I think we should, rather than say that neuromyelitis optica is secondary to the lupus, think about coexisting conditions, especially also be cautious rather than making a jump into a diagnosis of APS in this patient because the treatment they need is not really anticoagulation. And the cognitive dysfunction is perhaps the most common of all these manifestations, and sometimes can be severe and progressive, but more frequently subtle and subclinical. It is still poorly recognized because in daily practice, I mean, we do not really organize every day in clinic psychometric testing. Is something that would be very difficult to do. And, but definitely we need to think about this problem and to try to probably to organize a type of service for some of the patients that would need support from psychology, for instance, that still is a bit lacking, at least in our hospital. But here we have a situation where you have patients with multi-infarct dementia and global dysfunction, and also patients with minor manifestations that would include memory loss or poor concentration, difficulty retrieving word. Sometimes you have, or in many cases, associated depression that can play a role and contribute to create a vicious cycle of things. Of course, we would consider this type of manifestation possibly as a preclinical phase of CNS disease, but in some cases it could be a reactive situation to other concomitant conditions, patient with a chronic illness. And I just wanted to mention this nice systematic review by the group from UCLH Hospital in London, and looking at all the data and the studies published so far, basically it is quite clear that cognitive dysfunction is quite common in patients with antiphospholipid syndrome, up to 60% of patients. And there is an association with the wet matter hyperintensity lesions on brain MRI, but as well with ischemic lesions and cortical atrophy. So when we consider treatment in this patient, it is paramount to identify concomitant causes and treat them whenever possible, and in particular identify conventional cardiovascular risk factors. Also, we need to be very cautious in patients with CNS manifestations, especially when they have SLE. Receiving treatment with immunosuppressant drugs and steroids, always think first about possible infection. So we need to consider patients with or without SLE. Sometimes it's difficult to make the correct attribution if both diagnoses are coexistent. And if we suspect focal thrombotic disease or diffuse non-thrombotic disease, well, this can change a little bit the therapeutic approach, but a clear-cut differentiation is challenging in many patients. There is no standard treatment for non-thrombotic manifestations, and the symptomatic treatment needs to be used first, of course, but in patients, when you suspect an underlying thrombotic mechanism or presence of a persistently positive antiphospholipid antibodies, so in patients with a clear diagnosis of antiphospholipid syndrome, obviously the emphasis would be on anticoagulant treatment, in some cases antiplatelet treatment, but in patients with SLE, especially when the disease is active, of course, we need to use anti-inflammatory treatment, steroids, and immunosuppressant drug. We have lots of issues in this field. There is a lack of knowledge, but also we need to get more knowledge there, and we need longer-term epidemiological studies, more knowledge coming from registry, risk stratification. We need to know more about mechanism in order to inform the design of better clinical trials, which are extremely difficult to design in this kind of conditions. And I would like to say thank you for your attention, and also acknowledge my colleagues back in London.